Thank you very much, Alan, and thanks for inviting me to this stimulating meeting. I think also in our last talk, we just got a rigorous test of the hypothesis that observational data is crap. By the way, observational data are crap, but anyway. Indeed, if we're talking about comparative effectiveness, a kind of key question is comparative effectiveness of what? And it's really the treatments that we are seeking to compare in terms of their effectiveness, and yet I think we have a bigger challenge than almost any field in doing this work from the treatment perspective. So I'd like to just cover sort of three basic topics in my remarks this morning. First of all, the importance in general and uses of treatment definition, some of the approaches that have been adopted to date in trying to tackle this problem and some of the challenges they've faced. And then I'll specifically summarize some of the current efforts being pursued by a NIDER-funded project on developing a rehabilitation treatment taxonomy that I'm a part of. I just want to acknowledge the funding from NIDER, and the grant went to Marcel Dijkers at Mount Sinai and his colleagues there, and then subcontract to us at Moss Rehab. So it's kind of a Mount Sinai Moss Rehab partnership in this project. Well, let's start with why treatment definition matters. And of course, I probably don't need to spend too much time on that with this audience, but obviously, we can't really talk about efficacy or effectiveness of something unless we can define the something we're talking about. But importantly, one can define something well enough to do one's own study, but that doesn't necessarily mean it's defined well enough to allow replication of encouraging findings by other researchers, or obviously disseminating treatments once they've been shown to be effective to practitioners and others. Then also, although we might put this at a somewhat lower priority, to support the clerical functions, coding, billing, and so on. So if we're going to move to administrative data sets, obviously we need a way to capture the treatments in those kinds of data sets in a more summary way than we would do for a research protocol where we have a whole treatment manual or whatever. Well, why is it challenging? Perhaps this is obvious as well, but someone made the comment earlier this morning that we're not mostly doing pharmaceutical research, and that the models have been developed for pharmaceutical research, where everything you need to know is given by the molecular structure, the dose, the route of administration, and the timing, and you're kind of done in having defined the intervention. But obviously in rehabilitation, pharmaceutical interventions, though we do use them, are a small part rather than a large part. We have a lot of use of devices, but those devices have multiple attributes. Should we be defining the treatment as the device, or the treatment as the attributes that the device provides, which may be common to other devices, and there might be two devices that have similar names that have quite different attributes? Many treatments that we engage in are voluntary and interactive or experiential in the sense that the therapist can't fully determine the treatment. The therapist does something, the patient does something back, the therapist then tweaks what they do next based on what just happened. And that obviously makes it much more challenging to define. This is very analogous to what goes on in psychotherapy, where there may be general treatment approaches, but you won't stay with a client very long if what you do has nothing to do with how they respond to what you do. Obviously, in rehabilitation, we didn't just start trying to define treatments with NIDER's funding announcement. There have been efforts ongoing for many years, but they've been challenged for many years. Probably the most common way of defining treatment is simply time. And we have many research studies in the rehabilitation literature that you can look at that analyze outcomes in relation to days of treatment or lengths of stay, things that aggregate at the day level, and then you have a lot of other studies that have to do with hours of PT versus hours of OT. And you know, as much as we pay attention to those studies and talk about them with a fair amount of energy, the implicit message of them it matters not at all what went on in that rehab hospital, what went on in that PT or OT session. As long as you had an hour together, that was therapeutic. And I don't think any of us believe that, and yet that's the level that we're measuring in many of those studies. Another alternative that's been used quite a bit is what I'll refer to as intent-based treatment definition. So we name things according to the problem they're intended to solve. There's memory remediation. There's gait training. But the implication here, unless it's further defined, is that if a therapist really wants your gait to get better, whatever they do will make your gait better. If a therapist really wants to attack your memory, that desire, that intent, that goodwill is itself therapeutic. And alas, I think probably most of us don't believe that either. And so until we get down to what are you doing in that gait training session, what are you doing in that memory remediation session, we don't know, and we can't define it. And this was very evident to me. I participated last year on an Institute of Medicine panel to look at the evidence supporting cognitive rehabilitation in traumatic brain injury. And an awful lot of the cognitive rehabilitation treatments that we looked at were named in this way. So there might be 10 or 12 studies of attention intervention, but do you want to do a meta-analysis on them when, if you look at the individual content of them, they don't look very similar one to the other? And in fact, one of the prior attempts to synthesize the evidence for cognitive remediation did exactly that. They took all the randomized controlled trials of something called memory remediation, meta-analyzed them and said, does it work? But they included memory notebooks, mnemonic strategies, you name it, a lot of different approaches. Now, you've heard a little bit from Gerben about a piece of the work that's been quite influential in the last decade or so in rehabilitation, the practice-based evidence, which I would refer to, and I will, if I'm mischaracterizing it, I'm happy to have some feedback, but I would characterize this as sort of a refinement of intent-based. That is, it starts with grassroots therapists getting together and saying, we do gait training, we do bed mobility training, blah, blah, blah. But then the discussion continues, well, we have two different ways that we generally do gait training, and it depends on this and that, and here's what they look like, and now we can sort of subcategorize. But still, these are consensus-based discussions, and I think they're not uniformly theory-driven. They're often driven by sort of practical or procedural differences in one form of therapy versus another form of therapy. And so the question that this raises is there coherence to the way in which these subdivisions are arrived at? In other words, when we divide gait training into 2 or 3 subcategories, does that have anything to do with how we might subcategorize some other training in other skill area? Or do we do it from de novo in each new area? Now I'm going to make a case, as we have made in the project that I mentioned, that theory-based definitions are the direction that we should be going in. Consider a patient with limitation in active shoulder range of motion. Do we want to define treatments like ring stacking, putting dishes on high shelves, reaching to targets on the wall? Are those 3 separate treatments that can be used to treat shoulder restriction? And should we do comparative efficacy on stacking dishes versus stacking rings? Or should we abstract from those that the treatment, the active ingredient of that treatment is repeated reaching movements at end range? I mean, we don't need to quibble about the details, but in other words, these 3 things are not 3 different treatments. These 3 things are 3 trivially different sets of treatment materials for delivering the same treatment. And I think this is a particularly crucial issue in rehabilitation because many of our clinicians seeking to engage patients use materials that are patient relevant or patient specific. And if every time you pick a task that matters to the patient, you're delivering a unique treatment that has never been delivered to any other patient before, then we never have any evidence. But if those task variations can be encompassed within a theory about what the crucial characteristics of the therapeutic exchange are, then we can ignore the specific tasks or task materials and isolate the therapeutic ingredients. And this is analogous if you think about mainstream medicine. Do we really want to say that a small red pill is or isn't better than a large white capsule? Or would we want to consider those different molecules that both block beta adrenergic receptors, and that's the important critical feature. So what are the advantages of theory-based definitions of rehabilitation treatments? Well, a really key issue is that empirical data on efficacy or inefficacy that we collect based on those treatment definitions does more than add or subtract an individual treatment from the armamentarium. It supports or refutes a scientific theory. And my own editorial comment would be that rehabilitation has been somewhat slow to progress scientifically because, to a large degree, we've empirically compared this treatment to that treatment. And when the answer is it doesn't work so well, you eliminated one of an infinite number of treatments, which really moves us along fast. So it would be really nice if you could prune off a whole branch of the therapeutic tree when you get a negative outcome. So with theory-based treatment definitions, we can be looking at classes of treatments or dimensions of treatment that are supported or undermined by evidence rather than proceeding one by one. But the act of arriving at a treatment theory, and we have certainly in our projects found it challenging. Once you identify a theory of your treatment, it also has the additional advantage of helping inform the question of who are good candidates for that treatment. It doesn't prove who are good candidates, but it sets up hypotheses about who are good candidates, whereas an empirically designed treatment that just is a good thing doesn't have any implications for who would benefit. And it also has very specific predictions for what outcome measures should be responsive to the treatment. What does this treatment really change? Well, then a measure of that thing better show a change. Now, let me give you an example. And, this is the funniest research project I've ever been a part of because we have collected no data. We read articles about treatment, we argue, we write up attempts at conceptualization, we rip them apart, we find a counterexample 2 months later that causes us to have to go back and rethink something that we thought we had resolved. So that's the nature of this work. Fascinating, but frightening if you're used to data that is kind of solid and trustworthy. Anyway, the last few weeks we've been obsessively discussing canes and walkers and other mobility devices. Now, if we approach this from a treatment theory perspective, a cane is a member of a class of objects that reduce weight on one limb while increasing weight on an upper extremity, and thereby, in some way, increase weight-bearing ability. Okay, if we have a theory, now that's a very lame and quickly put together theory, but if we have a theory along those lines, then who can benefit? Does it make predictions about that? Well, would we expect a patient with a metastatic lesion to the femur causing constant pain to benefit from a cane? Probably not, because we're not assuming that in that case the pain is primarily driven by weight bearing. Or on the other hand, what about the outcomes we might measure? Would we expect that pain ratings gathered while sitting should be responsive to this treatment? Well, it's specifically offloading during weight bearing, so we'd expect that pain reduction during weight bearing would be the most critical outcome measure. So by more carefully formulating how this treatment does what it does and how it does what it does, we constrain both the people likely to benefit and the ways that we would expect to see benefit most clearly. Now, I'm also going to contrast two bodies of theory that we've been thinking about and writing about recently. Treatment theory, which I've begun to discuss, and enablement theory, which I'll contrast with it. So treatment theory, as you gather, specifies the essential ingredients that are responsible for the mechanism of action that changes the treatment object. Now, we've introduced, and in the writings that we're going to be publishing shortly, we're going to have a little glossary because we do have a certain amount of technical language. We've introduced the specific word treatment object to mean the most proximal thing that that treatment directly changes by its mechanism of action, and not the many ramifications it might have in the rest of your life, which fall under enablement theory and which I'll talk about later. So treatment object is the specific treatment target that the mechanism is affecting. So the critical thing is that treatment theory does specify how this treatment does what it does, but it says nothing about what the ultimate functional consequences of that are. If I increase your weight bearing, will you get a job? I don't know. Will you have improved quality of life? I don't know. Will you be able to walk? I don't know. Treatment theory doesn't answer any of those questions. Enablement theory, in contrast, specifies the expected ramifications of a change in one functional attribute on other domains of function. And sort of reciprocal to treatment theory, enablement theory doesn't care how that change occurred. In other words, if we have two different treatments that can reduce pain during standing, we predict the same impact on the patient, assuming they're equally effective, in terms of other functional domains. Might be none, might be a lot, but whatever it is, it doesn't matter what treatment made that change. All that matters is how much change was made in that initial variable. And I have joked that this diagram will probably be on my tombstone because I've referred to it so many times, but this is simply a very schematized version of sort of an ICF diagram, although I have not towed the line and collapsed activity and participation or body structure and function, but you get the picture. So the main thing here is that we have multi-causal connections from among these different ICF levels. And the reason we need to think separately about enablement theory from treatment theory is imagine that I had a treatment that was very effective in improving your sensory neural hearing loss. Well, can I directly say your language comprehension will improve? Well, no, you may have other reasons for having impaired language comprehension, like a left cortical lesion, for example, and then having the best hearing in the world doesn't make you a great language comprehender. Or if I make an intervention up here, can I assume that if I improve your working memory, you'll go back to driving? Well, no, it depends on other things. So enablement theory has to do with how many and where these different arrows are, and if you will, the relative weighting of them. So hearing may be more important for language comprehension than something else. And so if we had to choose between two things to try to improve to get some distal outcome, we'd pick the one with the higher weight, assuming we had an effective treatment for it. All right, let's go back to the cane. We're going to learn a lot about canes and very little about anything else. So the treatment theory, the cane may or may not increase weight-bearing ability, depending on how much weight it offloads. So we have the primary question of what's the efficacy of this cane in offloading weight. If it's a really flimsy cane, it won't do very well, et cetera, et cetera. Maybe where it's placed lateral to the body will affect how much weight it offloads. So these have to do with, does the cane effectively offload weight? And if not, can we make it better in that way? But no matter how much weight the cane offloads, I can't predict it's going to improve ambulation. I got to know whether the person has active use of their hip flexors, what their balance is like, whether they can see where they're going, and so on and so forth. So I can't make a straightforward prediction on ambulation. If they have no endurance, they may not walk even with the cane for that reason. So the point is, when we find that giving a bunch of people canes doesn't make everyone walk again, the next move should not be, let me build a stronger cane. Because the problem is not with the efficacy of the cane with respect to its treatment object. It is with our conceptualization of how that treatment object is related to distal and complex realms of function. And I saw this in a very concrete way when I did an evidence-based review of anti-spasticity drugs. This was many years ago when there were fewer drugs, but I think the story is pretty much still the same. We took published studies on many different anti-spasticity drugs. We sorted them according to patient population, chronicity, age, et cetera, and the intervention itself. And we tried sorting them into piles of it works, it doesn't work. Every way that we tried sorting failed. Didn't seem to relate to population, didn't seem to relate to drug, didn't seem to relate to age, chronicity. When we sorted based on outcome measure used, things largely fell into place. This is a little bit of an oversimplification, but every anti-spasticity treatment works if the target, the treatment object, is reduction of hyperactive reflexes and stiffness, i.e. positive symptoms of the upper motor neuron syndrome. No spasticity intervention works if the treatment object is independent ADLs or mobility. And yet, people keep developing new anti-spasticity drugs, I think imagining that one of them will make people walk again, as opposed to thinking, these are the positive symptoms of the upper motor neuron syndrome. There are some negative symptoms too, like weakness, lack of coordination, co-contraction, et cetera. Drugs don't do anything to those. Okay. Now, clinical effectiveness, which is ultimately, I think, what we want to talk about today, gets even more complicated in rehabilitation in this way. We have the usual split between efficacy and effectiveness that has to do with when you move out of the pristine, controlled environment into the messy world, do things change? But we have a different moving out, which has to do with when you want to use this thing to achieve some meaningful functional improvement, do things change? And those are two different things that have to be addressed differently. So clinical effectiveness, first of all, depends on the efficacy of the treatment in changing its object. So if we don't even have efficacy in changing the object of the treatment, it's extremely unlikely that we're going to have something better downstream. But if that is true, then we have the usual question, does it depend on the effectiveness of the treatment in changing its object, still the same outcome, when delivered by routine clinicians to routine patients? Still dependent primarily on treatment theory, just dependent on issues of quality control, heterogeneity in the population, and so on, that we've talked about before. But now, the effectiveness of the treatment in altering distal aspects in the population selected for treatment now depends very heavily on enablement theory. So no amount of optimizing the treatment with respect to its treatment object solves this problem. This requires a different form of research linking improvement in that outcome to other realms of function. Now, I think another important thing we have to think about in this type of research is how much to focus on categories versus dimensions. And I thought about this when Gerben was presenting the data about the orthopedic study in the nursing homes and acute rehab centers, in the sense that that was assessed in terms of categories, SNF, acute rehab, but you also saw that there was a dimension of intensity of treatment. So which of those should we be looking at, or should we look at both together? I mean, because clearly there probably are things that are different about SNFs than IRFs that aren't captured by the intensity dimension. But this is a frequent issue, and I think, for example, in the robotics literature on movement, mobility treatment, and also in some of the partial body weight support and a number of the sort of physical therapy interventions, it's kind of looking like intensity is maybe the paramount issue, and yet people are sort of putting things in categories and giving them names and comparing treatment A to treatment B. Maybe that's not where the action is. So another way to ask it is, what's the impact of training frequency, number of steps, amount of environmental variation during gait training, and so on? And you can see that at least in my view, the PBE approach still wouldn't have tackled this stuff. In other words, there's very much a categorical concept without measurement of continuous variations within the categories. Now, that doesn't mean, I think that clinicians and practitioners, and for sure billers and coders, need categories. So that doesn't mean that when we say intensity is really what matters the most in, let's say, mobility recovery, that we just say, give a lot of intensity. We can define either optimal settings or cost-effective settings of some of these continuous parameters, and then distill them into the Whyte gait training method, and then everyone will know from now on that that involves many, many steps delivered in a certain way. I hope you will call it that when you figure out what it is. We also have the choice of macro versus micro. So you could study community reentry programs for traumatic brain injury and focus on macro dimensions such as staffing, disciplines and ratio, degree of team coordination, approaches to goal setting. But you can't realistically capture all the elements of all the treatments delivered minute by minute in these kinds of comprehensive programs. So you're kind of pushed to take a step back and capture large structural issues. On the other hand, so you lose something of the microscopic view of what's really going on treatment-wise. But on the other hand, it is realistic to make the claim that a comprehensive multi-ingredient program should have impact on big macro outcomes. So you lose the tail of the specific treatments, you gain a strong prediction of impact on functionally important outcomes because that's what the program has claimed the ability to change. On a flip side, you could say, well, is conversational skills training using videotaping and peer feedback for TBI effective? There you could focus on, you could even do a randomized control of that versus something else within a comprehensive program and look much more specifically at how conversation skills change and so on and so forth. But you probably can't strongly hypothesize effectiveness for increasing the quality of conversations out in the world. I mean, we've trained both the patient and the partner, that we didn't train the grocery clerk, you know, blah, blah, blah. And then we for sure can't assume that improved conversational skills will enhance community reentry for everyone because there are other obstacles to community reentry. So here we get more granular detail on the efficacy of this specific treatment, but less ambitious claims about what that treatment can accomplish. So what's ultimately required of this effort at classification? I would say a clear treatment theory that specifies the observable or measurable active ingredients. So what are we claiming has to transact between therapist and patient for this treatment to be delivered? And then a measure of adherence or delivery of those ingredients in quantitative terms. So we risk the fact that people say they're doing a treatment, but when you really look at their behavior, it's not very similar to what we anticipate. Once we have both the definition and a measure of adherence, we can look at the relationship between the amount of the defined ingredients that are delivered and the change in one or more functional attributes. So this issue of theory-based treatment definition cuts across observational and experimental research. In experimental research, you need to show that the two groups really got different treatments. They better have different adherence measures. In the observational studies, you probably want to show that amount of treatment ingredients or closeness of adherence to the treatment protocol is associated with differences in outcome. Now, challenges, one more challenge to traditional thinking, but I would hope some compensating advantages, is that we are forced to break up some treatments that clinicians typically think of as single. So we talk often about a long leg brace. That's a treatment, right? But we would think that, first of all, we'd probably like to define that treatment not as a long leg brace, but as a device that increases the force required to bend the knee and ankle. Because that's kind of what it's doing, and if somebody comes up with another thing that does that in a very similar way, we probably would make very similar predictions about who it would help and what it would do. But you can't just hand somebody a brace and then say you treated them. There's picking the right brace for them. So there's the actual selection of the brace and the fitting of the brace to make sure it's the right brace. But the patient has to figure out how to put it on and take it off, or someone has to. And they have to learn how to walk in it. These, we would argue, are actually three different treatments. And why do we need to break them apart? Well, because you can give a very amnestic or cognitively impaired patient the right brace, but you may not be able to train them to don it and doff it, and you may or may not be able to train them to walk in it, and vice versa. So these have different theories of what it takes to benefit from them. Benefiting from training is not the same thing as benefiting from biomechanics. So where is this heading? Just to close and let you know where you can get the truth about treatment in the very near future. Our research group has planned a special issue in the archives of PM&R to roll out multiple interrelated manuscripts, as well as commentaries on those manuscripts, some of which will be written by people in this room. Much now depends on the reaction from the field and the work of others to refine and extend efforts at treatment definition and classification. We have encountered many challenges and complexities which will be unpleasant news to the clinical field. The only problem is we think they're really there, and you can't turn away from them. So the question will be, do we get tarred and feathered for turning out something that is complicated and burdensome, or do we get some support for the fact that it really is complicated and burdensome, and we're doing the best we can at systematizing that complexity? Thank you.